Hi, this is Rebecca Hergert. We're going to talk about oxygenation today, and I am borrowing my PowerPoint from my good friend, Mrs. Blake, with her permission. Concept is going to be oxygenation, which is you want to improve oxygen delivery to the lungs through oxygen administration, and that decreases the work of breathing. Gas exchange is the process by which oxygen is transported to cells and carbon dioxide is transported from the cells. You breathe in the oxygen, exhale out the carbon dioxide, and that's kind of breathing 101, oxygenation 101. You're going to look up your concept of oxygen. I'll put it in the PowerPoint itself, and no, I'm sorry, not the PowerPoint, but in the shell, so that your definition for oxygenation is there. Oxygenation helps with the H's. Supplemental oxygen prevents and treats hypoxia, which is low oxygen. Hypoxia is insufficient oxygen reaching the cells to meet the metabolic needs and demands of the tissues in the cells. Hypoxia results from hypoxemia, which is a decreased amount of oxygen in the blood, which is a deficiency in the arterial blood supply. Hemoglobin carries respiratory gases, oxygen, and carbon dioxide. So if you have decreased hemoglobin, you're going to have decreased oxygenation, decreased oxygen to the cells. You're also going to have a decreased amount of carbon dioxide that can be taken away from the cells, which puts you at risk for respiratory acidosis. And I'm going to let you learn all about that in pathophysiology. It's a little deeper than I want to go right now. But let's look at hypoxia. What does it look like? Have a lot of apprehension, a lot of anxiety, have a lot of behavioral changes. People are confused, they can't respond well, they have a decreased level of consciousness, they're drowsy. I had a patient that came back from PACU. It's the patient care unit they take them to after surgery to let them recover from the anesthesia. When he came to the floor for me, he asked his family, "So what did you have for lunch?" Well, that's an okay question, except that 2 minutes later he asked them again, and they had already told him, "So what did you have for lunch?" He was just grasping at trying to be cognizant. He was grasping at trying to be alert, trying to communicate with somebody. He just really was not, he just couldn't grasp a hold of it. He just could not be aware, could not formulate anything other than the very most basic thing. His oxygenation was not bad, however, his fluid levels were really down. He was getting blood. He had more than one IV. He was getting blood in one. He was getting antibiotics in another. He was getting fluids along with those antibiotics. Typically what I do is if I'm giving a patient blood, I hold off and don't give them their maintenance IV, and I don't give them any piggybacks. I wait until the blood is in, and then I give them the next fluid, and I run their piggyback, and then I run their maintenance fluid. He was so low on fluid. His blood pressure was so low. He was 80 systolic, dropping. I gave him everything all at one time. I needed to rebuild his fluid up. I let the blood flow in the one line. I ran the IV and the piggyback together in the second line and just was really trying to rehydrate him. And I could see the results of it because within 20 minutes, half hour, he began to be more alert, be more aware, was able to come up with different questions. I could see him relaxing, being less anxious, and less confused. So it makes a big difference. If you don't have sufficient hemoglobin to carry that oxygen and carbon dioxide, you're going to see it in your patient, but you don't want to let it extend for a prolonged period of time, because cell damage is cell damage. If you go without breathing for very long, you're going to die. Individual cells, if they go without oxygen for very long, they're going to die. So making sure that your patient is adequately oxygenated is really important. When someone is hypoxic, their heart rate will increase because they're trying to get the hemoglobin that you do have to as many cells as possible, as quickly as possible. They're not going to be able to tolerate any activity. They're going to wear out. They're going to get short of breath. They're going to need to sit down. the respiratory rate is going to increase in depth and in rate because, again, they're trying to suck in as much air as they can because they don't have a very good delivery system. The respirations may be irregular. You may have decreased or adventitious breath sounds. In other words, you may not be able to hear the air bellowing in and out very well, or that you may hear some abnormal sounds, some things that don't just sound like their pulse oxygen level. When you put the pulse ox on their finger, we're going to look at that. We've got one of those. I'm going to show you what that looks like. It's going to be less than 90. With an infant or a child, you don't want it to be less than 94. They're hypoxic if their oxygen level is less than 94 on a child. They're going to be dyspneic. They can have difficulty breathing. They may become cyanotic, which means their skin looks a little bluish, and that's from decreased oxygen levels. Their extremities may be cool because what your body is going to try to do is it's going to try to shunt as much blood flow and as much oxygen to the absolutely essential functions like, oh, I don't know, your heart. That would be pretty important. And your kidneys, you kind of sort of need that. So it's not going to be so worried about if a finger falls off, but it is going to be really worried about if your heart stops. So it'll try to shunt the blood to the internal organs to make sure that they stay competent and not worry so much about your extremities. You may begin to see some retractions. And what retractions are is in between the clavicle and in between the ribs, the skin will kind of suck in because they're sucking in so hard, sometimes even in the neck area, in the top. You'll see it just really sucking in. On kids, sometimes it's throughout their entire rib cage. They're just, you can tell that they're just pulling with everything they've got to try to get some more oxygen in there because they're just not getting enough. Anytime you see that, that's problematic. You need to address that. Make sure that the physician's aware and make sure that you get some orders to correct that. If you already have the orders, implement them. If it's a long-term thing, you'll see this sometimes with smokers, you'll see it on kids that have congenital heart defects. Their fingers will begin to club, so instead of their fingernail being straight, they'll begin to get an angle where the fingernail is kind of down a little bit. I'll find you some good pictures of that so I can let you see what clubbing of the fingers looks like. But that's a long-term thing. That's not going to happen in an acute care situation. So how's oxygen delivered? Well, it's a medication. You have to be careful. You can hyper-oxygenate somebody to the point that it becomes toxic to them, and you can also give them insufficient to where they go into respiratory distress. Bulk liquid oxygen can be stored in safe temperatures that is a gas, which is beneficial because people have oxygen at home. It can also be delivered through outlets in the patient's room. So they have regulators that will plug into the wall outlet, and you can adjust how much oxygen the patient gets through that. It's also available as a non-liquid gas under pressure as pounds per square inch in canisters. And the dose is given in liters per minute. How much oxygen you give a patient depends on their condition at the moment and what their overall condition is. If they have COPD, chronic obstructive pulmonary disease, they can't tolerate as much oxygen as someone else because the drive that causes them to breathe, you and I breathe, unless you have COPD, because the oxygen levels drop in our body. Our brain's notified that we need some more oxygen, we take another breath. People who have COPD, their oxygen levels are so low all the time that their brain kind of switches what triggers them, and they take a breath because their carbon dioxide level gets too high. With them, if you give them too much oxygen, they think they don't need to breathe anymore because you've gotten rid of so much carbon dioxide that they think they're fine. So without thought, without conscious thought, their body thinks it doesn't need to breathe. You always want to keep your delivery system at least 5 feet away from a heat source because it is explosive. It's a component of what is needed to burn. Be careful when you're transporting. Make sure those canisters don't fall over. If they break, it's a problem. Oxygen supports combustion. It's going to cause things to burn. An important thing to teach somebody that is just now having to start using oxygen is do not smoke and wear oxygen at the same time. Now, you might think that that's not necessary to tell them. I've treated enough facial burns to tell you, yes, it is. They need to know not to smoke while they're taking in oxygen because sometimes they don't link it and then they wind up with a severe face burn. Most hospitals are no smoking areas, so they need to not smoke on the premises, and that usually means the entire campus. That means they have to like get really far away, and they need to not be doing that if they are that able to go that far away. Our hospital that I used to work at said that if they went out to smoke, they had left AMA. They were done. Make sure that you don't have it around any equipment that's sparking. That's one of the reasons why it's important for anybody that brings in their own equipment from home that the maintenance people check it and make sure that there's no frayed lines, that it's safe, because it can and will start a fire. No petroleum-based gels, and that includes chapstick.